And thank you for joining us to learn more about Orygen Digital's approach to developing digital mental health tools. And really, we're going to talk a little bit about how they can be applied in practice. And we've pulled together a bit of a tour through some of the ways digital tech are currently being used in youth mental health, from digital services and blended care through to virtual reality and just-in-time interventions. We'll also spend some time talking about lived experience and participatory design, because one of the things we're really interested in is not just what technologies can do, but also to make sure that they're designed for people who will ultimately use them. So, as Molly has already alluded, we have quite a few speakers for you today. So it's not just Shaminka and I, we're actually a bit of a team effort. So we'll start with Dr. Shaminka, who will walk us through what blended care actually is, and what the evidence tells us about how digital interventions can complement traditional mental health care. And then on to Tiffany Lowe, who's from our Most Service Integration team, who will introduce Most, how clinicians are using Most as part of their regular practice as well. And then on to Professor Lucia Vermalja, one of our head of our OXR Innovation Lab, and she'll be taking us through virtual reality and just-in-time interventions and how that type of technology can be applied therapeutically. And then later you'll hear from Toby Wong and Remy Eden. They're both from our Orygen Digital YAG, who'll be talking to lived experience participation and what young people have taught us about designing digital mental health tools. And then last but very much not least, we'll close off with our brilliant AI research fellow, Dr. Isabel Scott, who'll explore some future directions and emerging questions that we have around AI in mental health. And you'll also see that we set aside around 20 minutes at the end for a bit of a Q&A and discussion too. But first, before I pass off to Shaminka, before I get into specific tech, I thought it might be useful to briefly explain what we are, what Orygen Digital actually does. We're a bit unusual in that we sit across innovation, research, and service delivery. On one hand, we're developing and testing new digital interventions and technologies. Alongside this, we're also conducting research to understand what works, how it works, and for whom it works. And importantly, we're also delivering services to young people, which means that we gain a real-time understanding of how these tools function in the real world. And this sort of just creates that continuous cycle where innovation informs research, research informs service delivery, and service delivery generates new questions and opportunities for us as well. So what you'll be hearing about today, including Most, Velo, virtual reality intervention Mind, and AI-enabled approaches, is that they all sit somewhere within this cycle. Sorry, just skipping to the next slide. There we go. And one of the things I really value about working at Orygen Digital is that we're an incredibly multidisciplinary team. Across the division, we have all kinds of experts: psychologists, social workers, designers, software developers, peer workers, data scientists, implementation specialists. The list could go on forever. But we all approach our problems and ways of developing solutions from slightly different angles. And I feel that's one of our biggest strengths. I've really simplified all of those different forms of expertise into 3 forms, really. But just to draw your attention to, I guess, digital design expertise for us really helps us understand what is technically possible and actually do that. Clinical and research expertise really helps us understand what's safe and effective and evidence-based. And lived experience expertise really helps us design ethically, mitigate unintended harms, and also to understand whether something actually makes sense in the context of young people's lives. So before we talk about any of our specific mental health tools, it's really worth asking a more fundamental question. What does the evidence actually tell us about integrating digital supports into face-to-face care? And to help answer this, I'm going to hand over to Dr. Shaminka.
Coming back to what we've been talking about so far. So research is one thing which is really important to us, because ultimately when we are dealing with real clients and real people who are in vulnerable positions, it's important that what we're actually providing does have an evidence base behind it. And so one of the things that our group set out to do with a number of collaborators, whose names you can see on this slide, is actually to do a systematic review of smartphone interventions, and really just trying to nut out like what the best model is for this intersection between digital and face-to-face care. So yeah, I guess this term blended care really just refers to whenever digital products are actually intersecting with the face-to-face world. So I would hazard a guess that many of the clinicians on this call actually do work in face-to-face settings. Maybe I'm wrong about that, but whenever there's that intersection between face-to-face and digital, we actually call it blended care in the research. But that intersection can be quite complex. There are lots of different ways that we can integrate digital tools into what we do. So a couple of definitions that are more prominent in the literature are an integrated use of digital products in face-to-face care, where we're really weaving in digital products into a face-to-face session, or sequential, where we're actually providing digital care before or after an episode of face-to-face care. We've actually sought to extend that definition, but before I get into that, I did just want to define a couple of terms. So synchronous and asynchronous are two terms that refer to how the digital part is actually occurring. So right now, for example, if you are live on the 17th of June, sitting in this particular webinar with us, then this is happening in real time. This is actually a synchronous interaction that's happening for us. If you're one of those people who's listening back to this recording and you're listening back and you're actually viewing this in your own time, then that's actually something called asynchronous, where we're out of sync. So that means that if you say something, I can't respond to it because we're actually out of time. But often when we send text messages, things like that, we're more engaging in an asynchronous way. Just wanted to define that quickly. And so the way that we've sought to define blended care is in 5 different ways. So the top one is integrated. You can see in this little schematic, the digital component down the bottom and the face-to-face component happening at the same time, and they're integrated in terms of care. The second type is concurrent, where again, the digital part and the face-to-face part may be happening concurrently, but there isn't actually an integration between those two things. So the clinician may know that there's some sort of app thing happening on the side, but it's not actually integrated into care. Next, we have sequential, where we might have an episode of care which is digital before or after a period of face-to-face care. And then we've actually defined this other kind of funny one called online synchronous, because we're even the definition of face-to-face care is somewhat changing today. Post-COVID, I hate saying that word, but after that, we've really seen a boom in telehealth. That's become part of the norm, part of what people often expect when they do receive care. And so even when we're sort of working in an online face-to-face setting, we can also be integrating digital tools in a more like a digital environment as a whole. And then lastly, we have asynchronous guidance. So a lot of digital interventions actually do have their own guidance built into them, like MOST is one that you'll hear about in a moment. But yeah, within that, there may be chat messaging or other sort of forms of integration of care, which actually don't happen in real time. So they're asynchronous. If all of that just went over your head, the key message here is that there are many ways to work with digital interventions. And at the moment, we don't actually know which one is the best option. We know that all of this is happening at the moment. All of these different forms of intersections between digital and face-to-face care are occurring. But we really wanted to know which one is the best option. And so we did this large systematic review. We actually reviewed all of the smartphone app research that has ever been done since the origin of the smartphone. We're in the process of updating this review at the moment. And we looked at all of these 5 levels of blended care, as well as digital interventions where there's no human support or no human attached to providing support through any sort of digital means as well. So I'd love to share with you the results real quick. So out of the more than 100 studies that we looked at, we found, unsurprisingly, that a lot of digital interventions focused in on depression and anxiety, being the highest prevalent conditions. That sort of makes sense. There were fewer apps available for more complex or lower prevalence disorders as well. And then when it came to the proportion of blended and self-guided apps, we found that most apps that were developed were actually self-guided, interestingly. About a third fit our definition of blended. And out of those blended apps, we actually had, about a third that proposed or did some research on this integrated form of blended care. Then we had our next most popular group was actually the asynchronous guided interventions. And then we had much lower proportions of the other types as well. So, big question, were smartphone apps effective? So when we looked at all smartphone apps that were developed for mental health conditions, we did find that these interventions as a whole were more effective than controls. And so there was good evidence for this. When we looked at comparing blended interventions and self-guided interventions, we found that actually, regardless of the type of care that was offered, these were all effective interventions. But there was one notable difference, that blended interventions were actually more efficient. So they achieved those same effects and impacts as self-guided interventions, so someone engaging in something on their own. They actually achieved those same impacts in a shorter period of time. So care was actually more efficient for them. And so then we looked at how effective each of these levels are. This is sort of a bit exploratory, so do take it with a grain of salt. But we did find that our highest ranked effective form of blended care was actually online synchronous. So where there was face-to-face sort of online care or synchronous care, which was integrated with a digital intervention. Next up was sequential. So actually when a face-to-face clinician sort of had their episode of care either after or before a period of care with digital, that was next on the list. Self-guided was next after that, and then the others came after that. Interestingly enough, we actually had to drop the integrated form of blended care from this analysis because there was so much variability in the ways that this was done that it became a bit of an unstable one. And so I think that really sort of points to this idea that there are ways that we could make that a bit clearer, how actually to integrate digital and face-to-face. So key points here. Smartphone app interventions are effective interventions, whether they are self-guided or blended, but blended care may actually be a more efficient way of doing care. Synchronous support tends to be, on the whole, more effective than asynchronous support, or if we're not doing such an integrated job of blended care. But of course, we need further research into all of this. So thank you very much for your attention. I'd love to hand over to Tiffany, who's going to tell us about MOST.
Hello, lovely to meet you all. My name's Tiffany. I'm the team leader for the implementation team with Orygen Digital. So our team work with Victorian headspaces and tertiary mental health services to support them to integrate digital technology, so in this case MOST, into their day-to-day processes and into their clinical work. So I'll be talking to you a bit about what MOST is, what supports it provides, and a few different examples of how you can integrate that into your clinical work if it's of interest, and how you can get started. So next slide, please, Shanika. Thanks. So in a nutshell, MOST is a free accredited digital mental health service specifically for young people aged 12 to 25. It provides mental health, peer and work and study support, and it was designed to support young people throughout different stages of their journey with the mental health system. So whether that be before they've gotten started, while they're engaged in face-to-face care, or as they're transitioning out of a service, whether it's to another service or back to community supports. And so it's been designed to be integrated into the mental health system and clinical work. So I'll talk you through some of that today. Next slide. Thank you. So just to give you a really quick overview of the types of support that MOST provides. So MOST offers young people access to a large library of evidence-based therapeutic content about mental health and work and study topics. And young people can save anything that they find helpful to an online toolkit. Young people can also support each other on the online community, so they can connect with other young people in a safe and moderated environment. and also receive one-on-one support, whether it's from career consultants, peer workers, or from our mental health clinician team. And I'll go through these supports in a little bit more detail in a moment. Next slide. So just to go back a little bit in terms of why MOST was created. So like a lot of things, MOST started off in research probably more than 14 years ago now. And the research was done in a few different clinical presentations in different versions. And at the end of 2020, we received funding to actually roll MOST out as a live service for young people to access. And so, as I'm sure you're all very aware, there are a number of gaps that young people can fall into when they're trying to access support, whether it's long wait times, difficulties navigating the system and knowing where to go. For a lot of young people, they may not have physical services very close to where they live. We know that young people can also maybe not get the right amount of support they need at that right time, or might need to return for multiple episodes of care. So MOST was designed as a digital intervention to try and fill some of those gaps by making it accessible to young people with the ability to be personalised to their needs. It's also been found to be clinically effective, which of course is very important, and designed to link up to different parts of the mental health system. So making sure that it's not just the standalone service, but that we work and integrate with the whole system. Next slide. Thank you. So to go into the different types of support, so I'll start with the therapeutic content. As you can see on this slide, there is quite a large variety of different formats that the content is available in. So the team have done a really wonderful job to make the content really engaging and youth-friendly. So there's audio, activities, videos, comics, animations. We've recently also included some really wonderful lived experience stories from our peer work team, talking about some of their own experiences and sharing things that have been helpful for them. And also videos from clinicians talking through different concepts, and even sometimes practicing different skills so that young people can really follow along and get a sense of what those skills might look like in practice. Next slide. Thank you. So one way that young people can engage with the content is through what we call a therapy journey. So these are structured modules that young people can work through in their own time with a clinician on MOST, or even with their face-to-face clinician or a trusted person in their life. And it breaks it down into sort of very accessible bite-sized pieces. So it starts off with an introduction to that presentation. So this is an example of our depression journey. So it starts off with psychoeducation and then moves on to 3 main concepts. So negative thinking, core beliefs, and energy and motivation. And then it finishes up with talking about relapse prevention and staying well. Next slide. And so these are the 7 different therapy journeys that are available for young people, and clinicians can also access these journeys if they would like to work through it with the young person. So you can see that it spans from an introductory journey through to more specific presentations that we know are quite common throughout young people. So depression, social anxiety, and generalized anxiety, sleep. There's also a journey about relationships and, of course, work and study. We know that work and study is, of course, a really big part of young people's lives. Next slide. So in addition to those structured modules, we also have a library of more bite-sized pieces of activities where young people can access standalone content. So they can have a look through the different topics. Some of those topics are on the left-hand side here, and really just pick and choose what they need at that time. And all of that content is also in that multimedia format that I showed before. Next slide. So with our community support, so the online community is a really lovely space for young people to connect with other young people. So they're very welcome to share their experiences, ask questions, problem solve together. They can even use it as a space to celebrate their achievements, talk about their hobbies, whatever is really useful for them. We know that there's a lot of young people who find this really, really beneficial, even if they don't post. So even just reading through other people's experiences and stories, we hear really lovely feedback that helps them feel, not alone in their experiences. And to keep sort of everything safe and moderated, we do have the peer work team who jump onto the community, respond to posts, generate discussion, and our clinical team are there as well if there's any situations where the young person might be at risk or appear highly distressed, so that we can offer them additional support. And then finally, so our one-on-one support, we've got our mental health clinical team who are available for one-on-one allocations with young people for about 6 weeks at a time. Their role is focused on supporting young people to identify what their goals are and really linking them in with therapeutic content that might be relevant and how that could be implemented into their day-to-day lives. Even if a young person isn't keen to have a one-on-one allocation, the clinical team are still there to respond to any sort of risk or any sort of distress. So if a young person posts on the community or in an activity, the clinical team are really great at reaching out to those young people to offer them additional support and also help manage risk if that's relevant. And they'll do so, they'll also connect with the young person's face-to-face service if they're still engaged, to make sure that, information is shared appropriately between services, and to make sure that they can provide a bit more of that wraparound care for young people. And then onto our peer work team. So our peer workers are also available for one-on-one support. It's a really great option if young people would like to connect with another peer and really, talk to someone who understands what it really is like to go through mental health challenges, talk through the experiences of recovery and what it's like to, hit those roadblocks. So it's a really great option if young people maybe don't want clinical support, already have had a lot of clinical support, and would like to talk to, someone who gets it. And finally, we've got our career consultants. So they can support with quite a wide range of work and study related topics. So it could be anywhere from those practical skills around applying for work, writing resumes and cover letters. It could be more exploratory around, looking at what their strengths are and their interests and how that might lead to different training or career opportunities, as well as things like exam stress and study skills. So another really great option to really support with those functional goals that young people might have. Thanks, Shaminka. Next slide. So in the last 5 minutes or so, I just wanted to talk through and just expand on a little bit of what Shaminka was talking about in terms of blended care and how digital interventions can be used in clinical work. Next slide. So with most and many other digital services, there is really no wrong or right time to introduce it to someone. So for most, it's been designed that in a way that it can be integrated into service models, depending on that service's unique needs. So a lot of services have integrated most at that initial intake or triage stage, so that it offers young people support quite early on in their engagement with them, whether it's to provide them with additional support, support while they're waiting on a wait list, or even support as they're navigating all of the other treatment recommendations that they might have been provided. Offering a digital intervention like most during treatment can also be really helpful and also look differently depending on the person. It might be providing additional support in between appointments, or even using the digital intervention in session, like Shaminka mentioned, in that integrated way. And lastly, at that approaching discharge stage, digital interventions can also be a really helpful step down. So a transitional support for young people, even if they don't need it at that time. We hear from a lot of clinicians that young people will say to them that it's reassuring to know that they have something that they can access when they need it. So there's no right or wrong, just sort of different ways that it might look. And so in terms of using it in your own personal clinical work, there, again, are many different touch points that you can have. So you might want to recommend most to young people so that they can access support when they need it. So it might just be a really warm recommendation, knowing that they could access evidence-based support at a time that they might need it, and that could be independent of their work with you. To go another step further, it might be recommending digital interventions with very specific reasons in mind. So for example, if a young person has a specific therapeutic goal around working on their sleep, it could be recommending most to support with consolidating some of those skills and concepts that you're working on. Similarly, digital interventions can be really helpful to fill in maybe some of the gaps that may be outside of the scope of your particular session. So if a young person has other goals related to maybe their employment or their work, or they're looking for peer support and that might not be available potentially at your service or in another local service, most can also support with those options to complement the work that you're doing. And then if we go all the way into that sort of integrated model, it could also be using most in your sessions. It could be recommending content, assigning activities for homework, and maybe liaising more closely with the most team to really discuss treatment planning and shared goals. So in saying that, I just wanted to give you a little, I guess, demonstration of what that might look like for a service that we're working with. So this is what we call the provider portal, and it allows face-to-face clinicians to access all of the therapeutic content that I've mentioned earlier. It also allows clinicians to keep track of who they've referred to most and whether the young person's onboarded. And then if it's relevant, they can also check in on the young person's progress on most. So it could be things like, is the young person allocated to a member of the most team for a one-on-one allocation? What therapeutic journey they might be on, and also some of their assessment results. So if I just go to the next slide, Shaminka. Oh, sorry, these are some arrows just pointing to where all those are located. Just to give you a little bit of an introduction just to our assessment. So if you might be familiar with the IAR tool, the Initial Assessment Referral Decision tool. Essentially, our onboarding questionnaire is a self-report version of that. So if you haven't heard of it before, essentially it assesses 8 different domains. And what it does on most is it helps, I guess, triage a young person's level of need for our most team. So if a young person does have a higher level of need, our team can be a bit more proactive about reaching out to them and offering them one-on-one support. And then for services and clinicians, they also have their own view of this, where they can access those assessment results if it's relevant for them, as well as any other additional assessments the young person might complete throughout sort of check-in assessments that pop up for them. Next slide. And then I just wanted to show you what most looks like. So if you're a young person or a clinician on the provider portal, this is where they would be able to access their content. So clinicians can filter by topics and create their own toolkit, so that when you're working with a young person, you've got almost like, you know, our old school, I don't know if people still do this, but I know that I had a big folder of all my handouts. It's like the digital version of that for clinicians. Next slide. That's just to show you that there's that's what your toolkit would look like. And then final slide. I just wanted to finish up, if anyone is interested in most and looking further into it, there's quite a lot of different ways at the moment that clinicians and services can access it. So in Victoria specifically, if you do work with a service that's already partnered with us, so a headspace or tertiary service, it's very likely that you will already be able to access it. So if I just go to the next section, Shaminka. Yeah, so it's very likely that you may be able to already start referring. That's the referral form there in the blue box. And then you can always email us if you want more information or access to that provider portal that I just mentioned. If you're not sure or your service isn't on that referral form, please email us anyway, because there is another way that you will be able to access most and use it with young people if that's of interest to you. But yeah, feel free to email us and we'll send you more information that's relevant for your specific context. So thank you. I hope that was helpful. I will pass back to Lucia.
Thank you, Tiffany. So one thing we have learned today is that I cannot use Zoom, that's for sure. But okay, but aside from that, so I'm here to talk to you about how to use just-in-time intervention and virtual reality. I'm a professor of clinical psychology and youth mental health and the head of the Orygen Digital XR Innovation, and my pronouns are she, her. Thanks, Minka. So if you, okay, you managed the slide. Okay. So yeah, you want me to, okay. So the co-design is at the core of everything we do. And I know that Shona has talked about it a little bit at the beginning, and after my talk, there is going to be more time to discuss that, but it's really, really key to understand that everything I'm showing you has been co-designed and co-developed with young people and clinicians, because as you will see, I hope it makes it also more effective and more engaging for young people. So next slide. If you think about just-in-time interventions, what are they? Well, it's really what it says in the name. So it's a opportunity for the young person, or indeed in this case for Mel, also an older person, because we open it up also for older people, is to have support in the moment when you need it in your real world. So they can monitor how you're feeling. For example, you can monitor your stress levels, or there are also some just-in-time interventions that monitor where you are, for example, closer to a busy space or closer to a green space, or indeed also can monitor some of your physiological measures like your heartbeat. And they aim to provide support between therapy sessions, or you can also use it yourself when you identify there is a moment that you're particularly worried about or find difficult, and how to cope with that. I'm going to talk about Mello. If you want, you can download it. As I said, the Mello is the one that we have opened up also to people who are over 25 years of age. And it's you can find it here on the mello.org.au, but you can also download it just from your app store. And what it's based on is this idea that we have a lot of research, over 40 years of research now, showing that one of the characteristics of depression and anxiety and distress is that you get stuck in your thinking and you ruminate and you worry and you can't get that out of your head. And with young people, we developed this app which enables you to get unstuck, if you like. And there are a number of activities that you can access when you need it. So you can get recommendation design to help you when you're stuck, for example, taking action or zooming in. Often they're also based on some of the things that we know work in getting unstuck, like mindfulness and acceptance and commitment therapy. You can build new habits by scheduling exercise or checking, and more, if you like, a behavioral activation type of thing. You can get proactive and learn a little bit more about different things that you can try. For example, expressing compassion towards yourself. You have little lessons that enable you also to understand more what's behind some of the techniques that we can share and that can help you. And then there is also an option for you to vent it out. So to say, you know, oh, I'm really struggling. And then you can just vent it out for yourself and revisit it at a time where you feel it's useful for you. And there are also, or indeed share it with your therapist. And then there are check-in moments where you can check in how you're feeling and how you're doing. And how you can use it, I will get to that in 1 second, but it's good to see that a lot of people have actually picked it up. We had over 10,000 downloads. A lot of people sign up and use it. A lot of people use it exercise, not all the time, you know. It's one of these things that you use only when you need it. But some people use it more often than others, of course, for a period of time, and then they use tapers off. And how you could use it yourself as a clinician, you might want to, you know, a bit like most really, you might want to say, well, would you like to use this in between session when you find yourself get stuck or ruminating about things? It can help you with homework and behavioral experiments. If you ask people to monitor how they're feeling, when and where, it can also help you at the beginning of your therapy to support the formulation. If people find it difficult to identify triggers that start their rumination, and if they're already on you know, the time for them to leave the therapy, it might be something that you want to show to them to help them thinking about relapse prevention and identify moments where the ruminating might get worse. For example, under exam time was a common one. So the key message really is that just-in-time intervention are evidence-informed digital tool, and please do check whether there is evidence, because there is a lot of there are a lot of apps, thousands of them that get you know, they live well, get out there in the world every day, and many of them have no evidence base whatsoever behind them, and they claim all kinds of things, but actually they don't really deliver it. So be careful what you use and how you choose it, and it can be a big support behind, you know, like having a little therapist in the pocket, if you like. Okay, now we move on to virtual reality and what virtual reality is. So big shift. So this is quite different. So it's not that you use it on your phone. This is you wear a headset, as you will see in a second in the video. And then we create three-dimensional environments that you can see and hear through the headset. And the images you see adjust in real time and enable you in real time to have a conversation with avatars and to you know, interact with objects. And it can be used, like in this case, for example, you can see a Rosebud Calder, who is one of our therapists, with one of our project manager, Carly, just for the video, showing how a young person might use virtual reality to practice in a social situation, in this case in a cafe, asking for a coffee and then have a conversation. And in this particular type of program, which is called Visor, the therapist voice is the avatar, and we modify the voices so that the voices sounds not like the therapist, but like the avatar. So if you like, what virtual reality does is it's not replacing the clinic in any way. What it does is you usually see someone in a clinic or virtually, for that matter, through telehealth. And what virtual reality does is enables you, like a little bridge, to practice things first in virtual reality in an environment that you can control and make as safe as you wish. So you can, you know, have a bar or a cafe that is completely empty to start with, and then populate it with more or less people who are more or less friendly. And also, we know importantly that your body, despite the fact that you know the situation is not real, responds as if it were real, because it feels and perceives it as real. and therefore your physiological activation is the same as in real life. And we know that from exposure, if you are exposed to a situation where your physiological activation is activated similar to the real situation, you're more likely to retain new information and new coping strategy. So it's really a bridge between the clinic and real life. And I'm going to show you an example of different projects that we have at the moment in the lab. And they range from mind, which I will show you in a second, also a little video of Visor, which I just spoke about. We have more training packages which enable you to practice. For example, in this case, vocational recoveries, to practice activities like asking somebody for a job or talking about your experience. And then we have a number of other that are a bit more experimental at the moment, looking, for example, what helps with conduct disorder or what enables somebody to approach or avoid people, just to understand what mechanisms and then translate that into therapy packages. And then we have also more fun things like helping the AFL young players to become stronger when they have to take a goal and feel less depressed if they miss a goal, for example. And I'm going to show you an example from Mind. And Mind was developed by Imogen Bell and colleagues. And again, it was co-designed with young people. It's based on acceptance and commitment therapy and mindfulness principles. And it guides users to learn how to practice therapeutic skills, and it makes it very visual. So in the video that I'm going to show you in a second, you will see this is the little avatar that takes you through the activity. And then this is all designed with what young people said they thought would be a nice representation of how their mind looks like. This is helping you with the breathing, for example. There is also audio, which you cannot hear at the moment, but we know that audio makes you more immersed in the situation, so we use that quite a lot. And this is more giving you a little bit of information of how thoughts work, and then help you to label, for example, in this example, a thought, and then throw it towards things or make it sound funny or move it around, just to give you a few examples of what is possible. So how could you use it in your care and your practice? Well, it can support experiential learning because you are immersed in the situation, like I was saying, and your body responds in that way as if it were real. You immediately, more readily, learn new strategies and that can help you through exposure. You can, of course, practice things, for example, emotion regulation. I work with young people in the criminal justice system, so emotion regulation is often an issue for them, and this enables them in a safe space to practice things that might not, always be easy to practice for them with real people in first instance. It can help with assessment and formulation. You can ask somebody what's happening to you right now, what's happening in your body, what's triggering, for example, a paranoid thought. Of course, behavioral experiments can be used. And just to say that people really engage with it, young people really take to it, they love doing it. Not everybody, but the majority of people, they feel quite natural in using it. And the benefits, of course, is that it's very safe. You can personalize it and you can use it over and over again and practice step by step. So the key message is it's not a therapy in itself. It's a tool that enables you to deliver therapy that we know are working in a more efficient way. There are a lot of articles and reviews now showing that it's cost effective, that you need fewer sessions, and The field that is a bit less researched is depression and in using VR for depression, and that's why Mind was one of the things that we developed, and we just finished a trial testing it and showing that it works, but that's not been published yet. So thank you for your time, and again, apologies for the disaster with sharing the presentation earlier, and I'll pass it on to Shona and the rest of the team. Thanks.
Oh, thank you, Lucia. And don't worry, it's a kind of a running joke at Orygen Digital whenever we do a presentation that we must demonstrate some level of tech literacy before we start. So thank you. And so, yeah, you've been hearing a lot about these different mental health technologies and interventions. And really, I have to say, VR is so popular with young people, both in participating in the interventions, but then also in participating in developing them. So what I'm doing now, really shifting our focus slightly to talk about the people who actually use these interventions. So just a slight definition kind of caveat here. When we talk about lived experience for us, we're talking about both lived and living experiences of mental health challenges and experiences of distress. I'm really just wanting to acknowledge that many of us in lived experience, consumer spaces, psychiatric survivor movements may use different language based on what feels apt for us and our experience. And so really, we just use this as a bit of a catch-all in our work at OD and work with people based on how they want to describe their experiences. For this, though, I am very pleased to say that I'm joined by Toby, one of our Orygen Digital Youth Advisory Group alumni, and also Remy, one of our current Orygen Digital Youth Advisory Group members. And they've both been involved in a range of co-design and other lived experience activities across our work and at Orygen more broadly. And so over the next few minutes, we're just going to explore a few questions, being what do young people actually want from digital supports? How do their perspectives influence what gets built? And finally, why does meaningful participation matter, not just for organisations like Orygen Digital, but also for the people involved as well? And so I'll hand over to you, Toby. Oh, Toby, I'm not sure we can hear you. Sorry. There we are. We can hear you. Wonderful.
Can you hear me now?
Yes.
Okay. Yeah, no, apologies. So yeah, no, thanks for introducing me. And again, I think we've covered this so far in the presentation, but there are already, a lot of different types of digital supports and tools out there, and they are already being used by young people, or not just young people, but people in general. And I think that, again, just to really summarize what works well and what doesn't so far, we can see and demonstrate it as well, even just now by some of the innovative, kind of interventions in VR by Lucia. But they are very flexible and they do, meet really specific demands and needs of different users that are using them. And especially compared to an in-person based support, they can be more affordable as well, especially because again, you might not need to travel for that specific type of support, or there aren't, again, maybe specific equipment required in some cases. But also what is important is that it complements, face-to-face care. So, and again, I think in this field, we might talk about it as blended care. These digital tools can support what may be, for example, happening in person with a psychologist doing therapy to help continue that experience and support the young person through that journey. And also, really importantly, and I think we can all see this in our daily life, these digital tools have means to connect us with different people or different services and needs. So it's not just, passive kind of things that, and again, there could be some tools that are like that, but they have a opportunity to provide social connection as well. However, there are and again, certain limitations right now, and this is, I guess, where there's a lot of work still being done. What doesn't always work is that given how diverse, again, the experience of mental health and the experiences of different young people are, they aren't always really personalized to the needs and kind of specific kind of backgrounds of those individuals. So that could lead to it not really working in the in the most effective way for all those different groups. Also, and I think this is something that Isabel will touch on later in like after our section, but it's not always clear, especially with these digital tools. There's a lot of data being captured, and this data is very, sensitive, very personal. If, for example, again, if a young person is sharing what they're talking about in therapy, or what their current experience is like, in maybe a moment of crisis, how is that data being used? What is, how is it being captured, stored? That is not always really clearly defined. And I think thirdly, and an important thing is that we have, again, a lot of research and work being done to translate clinical kind of intervention, clinical content that we know through experimentation works well, but that doesn't always reflect how people actually use things. Just because we know, well, again, in these experiments, this seems like it has some effect, that doesn't always translate to the lived reality, the actual like application for people. And so that's where, again, that adds a level of complexity. And one thing I also wanted to add, that it's not just these, again, I think so far we've talked a lot about tools that were designed with the specific, purpose and goal of having some positive effect, on, to support young people. But I just wanted to highlight again, also from my own lived experience, that there's a lot of other non-clinical tools out there that were not designed with those things in mind. And just to use two examples to really contextualize it, you might think about, again, during COVID, there was a rise in a lot of people playing this genre of what we call cozy games. So those, again, were not necessarily intended to be to support people's mental health well-being and connection, but they ended up having that kind of effect, right? And another popular example, again, just speaking about this with my friend last weekend, was around, habit tracking, motivation, and self-care based apps. So Finch would be one example. There are many out there, but these aren't necessarily clinical tools, but they and sort of they don't necessarily have that intended effect, but they do have a positive impact. So just wanting to highlight that as well. The non-clinical kind of supports may also lead to positive impacts as well, and maybe we need to explore more of that. So, oh, whoops, my bad. I think I clicked it twice. Oh, I'll click it one more just to go forward. So in terms of what we need from our digital supports, I think some of these are very obvious things and are very reasonable, kind of things to keep in mind. But I think especially when we are talking about young people using these different types of digital supports, these different attributes are particularly important. So just to go through some of them, agency in terms of, the type of support and how we engage with that product, service, or tool. Trust and privacy, like understanding how the data that you are providing, how is that being used, how that might be trained to improve, certain things. And that really ties in strongly with transparency as well, to just understand, again, what is the, what is the mechanism of how these tools work? Like, what is it actually doing? Are there any unintended effects or consequences that we don't know? The evidence base behind it, again, in some cases, maybe that's not, necessarily always needed to have a positive effect, but to understand what is the intended purpose and what is the supporting evidence to say why doing this will have that positive effect. Personalization. So, and in this context, I think in personalization, we mean how it really reflects, the actual experiences people have, and how that speaks to those different kind of experiences they have in order to provide, again, tailor the support to what they need. So it's not just generic and not really related to that young person's actual, let's say, experience of depression or anxiety, not some sort of generic kind of material. Uh, Accessibility, that's really important, how people engage with different tools. Again, there may be like specific accessibility needs, how easy it is to access, maybe their digital literacy may also impact how they are able to use these tools. And then finally, like human connection, which we've already sort of touched on as well. It's not just using these tools in isolation, but how do they complement other supports? And that could be formal or informal supports as well. And just, you know, as a question to think about when we think about these kind of digital supports, a question to think about is, to what extent do young people that are using these services actually have a say in how these experiences are designed? So how do they actually have a part to play in influencing the design of these tools that are meant to be, you know, for them to use? And yeah, so I'll pass it on to Remy to go into this in more detail.
I think it's on to me, Toby, but thank you
My
so
bad.
much.
Sorry, Shona.
No, you're fine. And yeah, as Toby was saying, that is the question I guess I'm looking at now, which is like, how do lived experience perspectives actually influence what gets built? So at least at Orygen Digital, I can say that we really aim to involve people with lived experience across the entire life cycle of our work. For this, we often use hybrid methodologies. So we include, you know, some things are co-designed. We're always applying human-centered design approaches. And we also, as a fundamental underpinning for all of this, is that we're grounding this work in lived experience-centered principles and frameworks as well. And so across that cycle, it starts with priority setting for us, really helping to identify which problems matter and where we should focus our efforts first. And continues through participatory design and co-design activities onto testing and content review. Those are common activities at that point, and then ongoing into evaluation and improvement. So importantly, this for us isn't just about making technologies engaging, although that is one great value of being able to work with those with lived experience in doing this work. It's really that we see lived expertise as a way of helping us to understand what success should look like and can look like, what problems are really worth solving, and then how the technology will fit into young people's lives. And to illustrate that, I've got a few examples, sort of mini case studies, I suppose. I've brought these examples together because I feel like they're quite different, and you can see how they work across that innovation, research, and service delivery cycle that I mentioned at the start. So the first example there at the top comes from MOST. It's a piece of ongoing work for us at the moment. So we're redesigning the Explore section of the platform. Tiffany would have shown you a bit of that. Explore is essentially our therapy content library. And right now we have content categorized through fairly clinically defined mental health categories. Whereas young people have told us in our early work so far that, of course, we're not necessarily searching for support using diagnoses or clinical language. Instead, we're looking for support based on how we're feeling, what we need in the moment, and how much energy we have. And so this has directly influenced how we're designing, how that content then gets reorganized and navigated. And it's also come into it as an aspect of like, well, what content are we also including in the redesign of this space? And what's our wish list, I guess, ongoing from there. The second example you'll see is from Sense AI. I'm not sure the team and I have landed on exactly how we're going to name this or refer to this project yet, but it's essentially a co-design project exploring research opportunities for AI-enhanced care. And so we did this as part of developing a grant proposal together. So for this work, rather than focusing on what AI could do, although we did do some of that too, we found that young people were repeatedly bringing us back to questions of trust, transparency, agency, what good data governance will really need to look like to make AI-enhanced care acceptable for them. We want AI to support decision-making, but not to replace human relationships or to make decisions on ours or our clinicians' behalf. And that work has become core design principles within that grant proposal. So we've been fortunate to win that grant. Isabel, principal investigator for Sensei, will speak a little bit further on this after us. And then finally, the final example you'll see there, again, calling back to the VR projects that Lucia was talking you through. For this was about Visor. So that's a VR-assisted intervention for social recovery for young people experiencing psychosis. So that was a really special project to co-design together, given that is also my lived experience. So in Visor, young people shaped much more than the virtual environments themselves. We wanted opportunities to practice skills and build confidence in safe and guided scenarios before then applying those skills into more personalized virtual reality sessions about our social lives, and then from there actually applying this in our real lives. So the co-design of that intervention directly changed the therapy protocol. It resulted in us developing together prototypes for these guided scenarios that ended up being built, personalized activities, and customizable avatars as well, and ultimately hopefully greater real world application. That trial is still ongoing. But as you can see from all three examples, lived experience expertise didn't just change the final product, but also how we understood the problem in the first place. And it really helps us to ask those different questions and think about how we're defining success, and then ultimately really wanting to create technologies that are hopefully more relevant for the people that they're intended for. Then I will pass on to Remy to speak a little bit more on what that experience is like and why it's so important.
Hello everyone, my name is Remy. I'm from Lismore, Bundjalung land. Got to get my thing up. So I'm currently a part of the Orygen Digital Youth Advisory Group. I've been on it for about a year. My background is that I've spent most of my life dealing with mental health challenges, which has been amplified by the fact that my town has been destroyed by flood 3 times. That's had a major impact on access to in-person mental health care for myself and also my community. And obviously that's also amplified by that being a very difficult time and events. I'm sharing this example because there's so many different life experiences and challenges that young people face, and it's really important that we acknowledge and understand that in order to develop digital mental health tools that are going to be actually relevant and effective to young people. Involving young people in co-design allows for a better understanding of what young people really want, especially when there's generational difference. There can be many blind spots for researchers and clinicians. In the Orygen Digital YAG, in this past year, there have been so many different stories and opinions shared, many of which were not necessarily obvious to researchers. Lived experience in participatory design and co-design is invaluable to the development of digital mental health tools, but it's also critical to acknowledge the role that lived experience work plays in a young person's life. So empowering young people to be able to shape and contribute to the state of digital mental health tools can inspire hope and a better understanding of the future of mental health tools. Young people, especially those who are experiencing mental ill health, tend to be in a really turbulent time of their lives and often lacking confidence, direction, and support. Involving young people in advisory work and co-design allows them to build essential life and work skills, communication, and collaboration skills. It also provides a great opportunity for social connection with other like-minded young people, as well as potential for future mentorship from facilitators down the line. So I started doing co-design and advisory stuff when I was 18 and in year 12. So it helped me a lot with my confidence and understanding myself. And I would also say that my ability to work collaboratively and to communicate has increased a lot by doing advisory work. And I've been able to apply that in day-to-day life as well. So it's really great. Another point is that young people experiencing mental ill health are statistically underemployed and more likely to be living in poverty. So being involved in co-design allows for a financial opportunity for more financial stability and independence, which can have a really massive impact on young people. It also allows for potential further involvement in co-design and lived experience, as well as career development. So an example would be going on to work with Orygen or another organization in a more formal employment role. So yeah, I started with Orygen 2 years ago. I've gone on to be involved in a bunch of other projects with other organizations. I was a panelist for a conference last year, so that was really cool. And I also co-authored a paper, kind of. I'm also shouting out Shona. She started with Orygen in an early trial for most and she was participating in qualitative research activities and reflecting on what worked and didn't work about the most platform. And then that motivated her to start participating as a lived experience advisor at Orygen and then go on to be a peer worker at most. And now she runs the Orygen Digital YAG, the advisory group. So it's really cool. Shout out Shona. So yeah, what I want people to take out of this is that there'll always be a fundamental gap between young people and researchers, as well as young people and clinicians. Involving young people in the development of mental health tools helps bridge that gap and allows researchers and practitioners to understand what, how, when, and why young people desire certain aspects of digital mental health support. This creates a space for practitioners to better understand and support young people, and it also creates an opportunity for young people to learn essential advocacy skills that they can apply in further advisory work, but also in their careers and as well as advocating for their own mental and physical health needs. The more young people that are involved with co-design of digital mental health tools, the more relevant and engaging and effective those tools are going to be. So my final little bit is that there's one quote that's really stuck with me doing advisory work, which is nothing about us without us. So that's originally coined by disability activists, but it continues to ring true in all aspects of lived experience and co-design work. So that's me. Thank you.
Thanks, Remy. And yeah, just wanted to highlight as well, completely agree. As Shona mentioned earlier, like I was previously on the YAG as well, and I think I've also taken away a lot, being, beyond that and in other roles and even in my work role, um, especially because I work in tech now, and a lot of these kind of learnings from what we, experience and hear from other, young people, like, and their actual lived experience has really like shaped how I also, do my work, and even for us to be able to speak here today about it. But just before we wrap up our section, wanted to highlight again, Remy's really, succinctly highlighted all of the benefits of having lived experience participation in designing these tools. Just wanted to show what happens when that doesn't happen. When young people aren't in the room and their voices aren't being involved in building these digital tools. And I think it's very obvious from what we just said, there are a lot of risks and there are a lot of potential consequences, maybe some that are neutral, some that are negative. But really, the key message I would want everyone to take away is that if we don't have, whether this is young people or whoever that key user is for these tools, interventions, or programs, these tools then get built with assumptions, and maybe they may not immediately have a negative consequence, but they do have that a likelihood to like rise up. And I think even and on the first part, like when things are built on assumptions, those intentions can be good. We can, again, based on research or based on just general knowledge in the industry, like we can know certain things, and there can be a lot of clinical evidence to support certain things. But back to what I said earlier around like what young people need in digital tools, clinical, evidence doesn't always mean actual application. And so if these tools don't actually fit how those users will use them, then it's not going to work well. Um, I'm not going to go into it too much as well, but Isabel's also going to highlight how AI really raises the stakes for this. But I want to emphasize it's not just about AI, it's any emerging tech or emerging thing that comes out. As these new technologies and innovations come out, there are going to be new ways that we expect or don't expect these things are going to be used. And finally, that would lead to the potential consequence, not just to harm, but to also like have people not, disengage and not actually be able to benefit from the potential, I guess all those positive things that Remy had highlighted to actually support them in their mental health journey. So again, thank you very much, but just, yeah, something to keep in mind that when looking at these kind of technologies, it's not just, fixing it, but also making sure who we involved in the room to, solve that together.
Thank you so much, Toby. And I guess with that, we'd like to leave you with two reflective questions for you as practitioners. So really, how much do you know about the ways that your service users seek support when they're not sitting in front of you? It's the majority of the week, for example. But also just thinking more broadly as well, how might our services change if those with experience were treated as a valuable source of expertise? And so as Toby highlighted, those questions become more important as new technologies emerge. We, can risk scaling, products and services that don't really work at a much greater scale, much more quickly. So as we start to think about AI and the future of digital mental health care, The challenge isn't simply about building powerful technologies, it's really ensuring that they're developed in ways that people can understand, trust, and meaningfully influence and have a say in. And so to explore some of those opportunities and challenges, I'm going to hand over to Isabel.
Thanks for that, Shona. So as introduced before, I'm a research fellow in artificial intelligence with Orygen Digital. So I'm going to be talking about AI today with respect to mental health. And just to get us on the same page, I'm going to be focusing on what I would call contemporary or modern artificial intelligence, just recognizing that AI is actually a broad term. It's been around for a while, but I'm going to be using AI to refer to things like machine learning, deep learning, generative AI models like ChatGPT, which actually use data sets to learn complex patterns and take actions accordingly. And that's differentiated from old school AI, which use predefined rules to sort of mimic human intelligence, like your very old school chatbots, which carry often lower risk than some of this contemporary AI that we're seeing. And so I'm going to focus on the contemporary modern AI. So I won't go through this in detail in the interest of time, but I just want to highlight that there are a lot of active areas of research in artificial intelligence. A lot of those areas aren't really making it to practice, in a big part around regulation. Anything that is going to be supporting and informing clinical decision making or guiding clinical decision making needs to be regulated as a software, as a medical device, which means that there's a higher level of regulation than something like scribes, which we've seen scaling quite readily, and that's because they're meant to be supporting administration rather than that clinical decision making. And so there's a different level of regulation there that's actually a bit lower. Where we're seeing the TGA being quite active is around wellness products, which are sort of being able to offer mental health support, but not necessarily designed for as such. And so they're sort of skirting that regulation boundary. So just being aware that that's an active area of research for the TGA, and there's likely to be some newer regulations around that due to concerns. Oh, sorry. Yeah, so just jumping into the practicalities. So we see a lot of opportunities for artificial intelligence, but there are a lot of risks associated with it as well too. Too many really to list here. So I'm going to talk about some general ways we can actually think about the risks if a vendor is coming to us or we're interested in a specific AI mental health tool. What should we actually be thinking about with respect to these risks? So the first thing is really thinking about the scope of how the technology is being used rather than just the technology itself. So for example, a large language model like ChatGPT, if it's directly interacting with a young person, providing them mental health support, that is very different in terms of the risk to that same piece of technology being used as a scribe, for example. While a scribe still carries potential risks like factual errors or loss of information, it doesn't carry the same risks as if you're having open-ended inputs and outputs direct to a young person without that clinical oversight, for example. So thinking about the actual scope, not just the technology that's being used itself. We can also see, for example, large language models even being used behind the scenes where they're actually not interacting directly with a young person or a clinician, but they're looking at matching data to pre-specified therapeutic content that we know is safe. So again, there's a different level of risk there to think about. The second thing is if a vendor is coming to you, to be really concerned around what they're presenting to you and to be armed with the sort of questions that are going to be important to yourself, your clinic, and the consumers that you are supporting. So one of the examples I see, and Toby talked about this before around transparency for young people, is what is happening to the consumer's data. And one of the things that is different about AI is that it's not really enough to just say that the data is stored in Australia. The reason is that often AI models are hosted overseas, which means that at the time that the AI wants to generate an output, it means that they actually send that data overseas, even if it is stored in Australia. So I would be asking, is the data ever sent outside of Australia rather than just where it's stored? The second thing, and again, Toby pointed towards this, is what's happening with that data? Is it being used for further research? Is it being sold to third parties? A lot of the time we see that vendors will be talking about that data being used, but it's all anonymized. I would caution against that because we know that anonymization is imperfect, whether it's done by humans, whether it's done by AI tools. We know we still see personal identifying information slipping through. And so I'd be really cautious about saying that's fine if it's anonymized. Also, what's the actual oversight? So is there clinicians? Has it been designed with clinicians? Is there clinicians monitoring the output? Vendors being able to actually describe what that looks like? What does it look like under the hood as well too? It's important to recognize that you may have a nice branded digital tool with a nice name, but often those are actually using models like Claude or GPT under the hood again too. So are you comfortable with that? Would your consumers be comfortable with that? We know that AI models change in terms of their performance over time as well too. So how is the vendor actually monitoring that, and how are they mitigating any decreases in performance as well? And have they even thought about bias in their models? Have they actually looked at how this tool performs for different groups? And especially with respect to the groups that you're serving. And so that's the next thing I'd come to, is thinking about the population that this tool is being used for. So as an example, I don't think vendors should really be claiming that they can completely mitigate bias, because AI tools generally go towards the preferences of the data that they're trained. It's just a design feature. So instead of thinking about, oh, is this vendor claiming that I can mitigate all biases, understanding what is the bias of that model, who will it work really well for, who won't it work well for, and who am I thinking this tool will help serve. So for example, if you're thinking about a marginalized community, that might not be the right tool for them if it hasn't been designed for that group. So this replicates a lot of what Toby's talked about with respect to what young people value in terms of digital tools, but we specifically asked them what they value in terms of if we were going to design a generative AI digital tool, and where could they see potential benefits, which I think points to, just as Toby phrased it before, that AI amplifies the stakes. So we're still looking at the same sort of problem areas here and the same sort of values around these tools. But as I mentioned before, there's additional concerns that AI would raise. So we worked with 9 young people across 4 sessions to understand what problems they could see generative AI supporting and what values were important to them in the design of those tools. We saw transparency again coming up, so around what's happening with the young person's data. The AI system's not replacing that young person's decision making, but actually seeing it as a tool where they can share back on what is and is not working for them in their care. And again, that idea of AI not replacing human support. I won't go through the benefits here, as Toby sort of spoke to them already, but just wanted to highlight that again, for us, personalization is something being quite holistic rather than symptom matching was a big kind of feature here. So thinking about things like cultural identity, for example. So in practice, there's a few tidbits that came up out of these sessions as well too. One of the interesting ones was around concerns around informed consent, with AI scribes being the big one now that they're being rolled out. So young people voiced that there was concerns around AI scribes often being presented in a way where it's reducing the amount of time a clinician would spend on note taking and increasing that face-to-face time with the young person, which doesn't seem sort of bad if you kind of just think about it. But for a young person, the implication for them was often felt like if they said no to the tool, that they were going to receive worse care and that they would be increasing the burden on clinicians. So just being really careful about giving the young person a really clear opportunity to opt out and not feel pressured into using scribes. Again, kind of going back to these points around understanding what happens to the young person's data and being able to share that with the young person, and also around not reducing their agency and access to human support. So with that in mind, we've got a few areas of research that we're embarking on, some more short term where we see lower risks, and some longer term where we see opportunities, but areas where we need to improve the models. So we've got a piece around personalization, that being a really key area of opportunity, but not thinking about open-ended inputs or outputs with young people, but thinking about that opportunity to match their data to the best content that we know is safe and evidence-based already for them. And then we've got a longer piece of work where we're looking at those opportunities around access, continuity, and agency, but recognizing that models aren't currently fit for purpose because they do carry a lot of those risks that I mentioned before. And so we actually need to think about how do we improve the models and think about the scope under which they should operate. So just as an example with agency, giving a young person an opportunity to feedback in their care. If we use an AI model to do that, how does the AI model navigate if, for example, that's in conflict with what the clinician thinks is going to be the best route of care to support the young person? What sort of should it be prevented from operating in that sort of scope, or can it operate in that sort of scope, and how does it navigate that? So we've got some pieces of actual methodological research we're doing to address some of these issues. And with that, I will leave it there. I think we're pretty over time, but I think we're at the Q&A next.
Thank you so much, Isabel, and thank you to everyone for your wonderful different parts of the presentation. We are a little